I'm talking about pain management and the older person. So really, I'll go through a little bit of basic stuff about pain management, but not in too much detail, and more want to focus on the older person, especially those older patients that have difficulty communicating their pain needs to us. And I'm sure that you have a lot of those people in your settings and where you work that struggle to be able to communicate their pain needs to you. Can you think of any at the moment and type some in down the bottom? The sorts of patients that manage that identifying their pain needs is difficult, and for what reasons? Write some in the chat box at the bottom if you can think of any. Yep. So delirium, dementia, confusion. Yeah, definitely. So English as a second language, other languages, even kids, people with intellectual disabilities, people with neurological problems, people with head disease, a whole range of people that some of this information can apply to. I guess this is sort of more aimed at the older person in the orthopaedic area, but you could probably apply some of the concepts to all those people that we just talked about as well. So there's lots of different applications, I guess. What I'm presenting today is based on some research that I was involved with back many years ago in 2008 when I was working at the Royal Adelaide Hospital, and it was in conjunction with the University of Adelaide where I work now. And I'm assuming everyone knows me. Sorry, I should have introduced myself better, but I'm a lecturer at the University of Adelaide, so I run the current orthopaedic grad dip program there. So. But I'm assuming everyone may know me and recognise everyone's names. Anyway, so the stuff I'll talk about tonight is based on some of that research. So part of the process that we went through when we looked at pain management of the person was to sort of map how pain's managed on the ward and the sort of steps that nurses and the patients go through, and the doctors and anyone else involved goes through when they're trying to manage someone else's pain. So the patients on the ward, they complain of pain, the nurse assesses that pain, they discuss with the patient, the type of pain and the sort of analgesia and all that sort of different information. They might ask the doctor to review the patient if they don't have any current orders for analgesia. The doctor might come along, assess the person. Hopefully they do. They don't just make it up without looking. They might order some analgesia, depending on the age of the patient. If they have had a history of any sort of other long-term opioid use, then that may change the dosage and the frequency, etc. But generally, they'll assess the dose and type of analgesia to provide, consider the sedation level of the patient and what sort of previous analgesia they've had. The nurse then generally administers the analgesia, and then they observe and assess the person again to see how effective that's been. And so then that then comes back to this step back here. So it's a cyclic process, and you assess the patient's pain again and see how effective the analgesia has been. Looks like Laurie's just joined us. Laurie, can you hear me okay? Just type in the bottom left-hand corner of the screen and press enter. Laurie's from South Australia as well. Yep, she's typing. That's a good sign. Excellent. All right, welcome along. So that's generally the usual process of what happens. Now, the area that I was concerned about or wanted to look at was this area here that I've highlighted in blue. What happens if when the nurse is assessing the person's pain and they're unable to communicate their needs effectively? And we identified some of the reasons before. So things like language barrier, dementia, delirium, head injury, child, someone with disability, all those sorts of things as well can make the assessment much more difficult. So if it's a language barrier, you might use an interpreter or a family, and that may help you around the the difficulties. But if it's because the patient has dementia or delirium or both, then that can make assessing the pain needs a lot more difficult and not quite as easy. So often we'll look for things like non-verbal signs of pain, vocalization, facial expressions, behavioral changes, and physiological changes as well. So that's the sort of area that I wanted to look at and consider that, especially in the acute care setting. Now, this use of these sorts of tools in looking at behaviour and non-verbal signs of pain has been used in aged care for a long time, but I'm not really aware of other areas that use it in the acute setting, and it's something that we wanted to consider in this research as well. So that's what we did. We went and had a look and we assessed some patients and we did some measurements, and then we came up with some interventions and a tool that I'll talk about a little bit later on, and then implemented that and then came back and re-audited to see if that had improved patient's assessment, and it seemed to work quite well. But we'll get to that in a little while. So why consider this patient population? Well, often for the elderly patient, they have different needs in terms of their pain management, but also they're more at risk of dementia or an acute delirium as well, especially in the orthopaedic area. We have a lot of older patients with fragility fractures, and they may have an underlying dementia and then develop an acute delirium on top of that as well, and that could make managing their pain very difficult as well. The other reason I considered this patient population as well was because, unfortunately, sometimes the squeaky wheel gets the oil. And so if you imagine a 6-bedded bay in orthopaedics, in the first bed there's a young guy, he's 20 years old, he's got a fractured femur and he's in a lot of pain, and he's yelling out and screaming and carrying on and telling you that he's in a lot of pain. Any nurse that's looking after that bay knows that young guy is in pain and he needs his pain managed. That's straightforward stuff. The problem might be is that in bed 6 over in the corner, there's an older 85-year-old man who's got a neck of femur fracture, and he's in just as much pain, but he has quite advanced dementia and is unable to communicate, and he's just sitting in bed sort of rocking and moaning a little bit. And sometimes when we're busy and we're caught up in other stuff, it's hard to see that, and I think that's one of the reasons I wanted to approach this topic and look at this patient population as well. Is that something that sort of seems familiar in your practice in the wards? Or it's not? And type something down the bottom. Yep, so that seems to ring true. Yep, that's good. So I guess the question is, how do you go about trying to change that? It's quite a difficult thing, I guess. Nurses are busy. We've got lots of demands on our time. So how do we go about trying to improve the awareness of those patients as well? So part of what we did for the research was look at some of the reasons that may make assessment of these patients' pains very difficult. And this is lots of writing on this slide, and I don't expect you to read it all, but we sort of grouped them into things about communication, about some staff issues, about how you assess someone, about the patient, and about communication and documentation as well. So we sort of tried to identify some of the areas that were might be the cause of the problem and make changing things a little bit difficult as well. And it was it was a good process to go through, I think, and actually take time to look at what happens and how it all works together and what we can do to maybe make that a little bit more effective for our patients. So going back to some of the sort of more basic stuff of pain management, I guess, is generally nursing or healthcare system knows how to manage pain relatively well. Whether or not we do that is a different story, and a lot of the literature says that we don't. And it is difficult. I mean, managing pain is very, very difficult, I guess, because there's lots of barriers in the way. It's a very subjective experience for the patient. The same injury for 10 different patients will be experienced 10 different ways, and they'll need 10 different types of interventions and levels of interventions, and that can make it really difficult as well. And I think one of the things that we don't often get right in nursing is We're very good at assessing. Sometimes we don't do much with that assessment. If we do, maybe we administer some narcotics and we think, okay, that's it, move on to the next problem, and then we don't go back and close that loop and see, okay, did that work? Do I need to increase the dose next time? What about the frequency? What about some non-pharmacological interventions? All those sorts of things. It's hard to take time to consider that as well. So sometimes we don't do all that well in pain management area as well, but it's not an easy thing. So I don't want to be too hard on nurses, and I know when I was working on the ward, I was exactly the same. I found it very hard to effectively manage people's pain sometimes, especially when some people have quite a high expectation of being in no pain, or they communicate it very challenging ways as well. It's a subjective experience, so everyone experiences it differently, and we need to rely on that experience and that description of that experience for each person. And that can be hard sometimes, because if someone says to you as a patient, I am in a great deal of pain, but they look like they're comfortable and they're sitting there chatting away, you might feel like, well, those two things don't match up. But really it's about asking the patient, getting their view on what their pain is, obviously understanding if there is anything, if they've got a history of drug seeking, or they've got a long history of substance abuse, that may come into the consideration, but at the same time you need to take account of what the patient's saying as well. So, and it can be hard to measure. How do you measure pain? And obviously one of the most common ways is the scale, 0 to 10 or something like that. I was actually in hospital at one stage, and I came out of recovery and they asked me how my pain was, and I said, oh, it's about a 7. And she said, oh, no, we only use a scale of 1 to 3 here. And I was like, oh, okay. So it didn't seem like a lot of room for me to go with my pain score. So I found that a bit interesting. Do most people use the 1 to 10 pain scale in their practice? Yeah, it's pretty commonly used in 1 to 10. Yeah, some people say, oh, there's too much of a range, but I like the concept of you ask the first time, the person comes up with a number, and almost in some ways that number is irrelevant. It's more about you give the analgesia, you come back, and then what is the difference to that number? So if they started off with 7, you administer the analgesia, you come back 20 minutes later, half an hour later, and they say it's 4, then you know that it's worked. If they still say it's 7 or 8, then obviously that's not doing what it's needed to do. So that's, I think, where the value lies in having that wide range as well. It takes time, so busy nurses, it's hard to come back and do that other assessment and make sure that things are working well. And we need to allocate some importance to pain management, which sometimes, unfortunately, nurses don't do that because you're not experiencing the pain. Has everyone here had severe? I assume some people here have had babies, so they'll definitely know what bad pain's like. But has everyone had quite severe pain? I assume. Yep. So renal colic. Yeah. Oh, Laurie. Oh, that's good, Laurie. I've had okay. I've had cholecystitis, and that was very unpleasant. So Claire's had this, but not childbirth yet. Cool. Oh, okay, Maria's had 2 diseases. So I guess if you've had severe pain, you can sort of understand it. It sort of gives you tunnel vision, and you're very focused on yourself, and it's a really, really unpleasant feeling, and that you almost do anything to get rid of it. So it's good to, I guess, to appreciate that as nurses, and we can sort of look at how we manage patients' pain. So what's different about an older person, and how do their needs vary? Um, there are some physiological and psychological differences in managing older people's pain. Do you have any ideas about how pain management in the older person might be different? And type something in if you can think of anything. Yeah, definitely. So that their ability to metabolise and excrete the medications is quite a lot different. That's probably one of the main ones. Everyone's getting that one, that's good. So just wait while the last people talks. Potentially, yeah. So more sensitive to some of the side effects. And they might be on a lot of other medications, so they might having polypharmacy and lots of other medications that might cause problems. Yeah, there is the next slide talks a little bit about how older people interpret their pain and how they tolerate their pain as well, which can be quite interesting. So I'll move to that slide. This is from the Australian New Zealand College of Anaesthetists quite a long time ago, back in 2005. But and I think, Mariana, you're right. There's older people tend to experience and tolerate pain differently to younger people. So this outlines it quite well, I think. It says management of pain in the elderly differs to that of other groups, and this primarily includes the presence of coexisting diseases. So I think a few of you talk about that, Laurie, and I think there was another thing about some of their other diseases as well, which can be a problem, but they're concurrent medications. Pain management is further complicated by physiological changes, so things like possible increases in body fat, decreases in muscle mass, lowered liver and renal blood flow, and decrease in cerebral blood flow and volume as well. So there's actual physiological reasons, and you guys have identified those mainly in there as well. There's also some studies that identify that for the elderly patients, the pain threshold is actually generally a bit higher, but once that threshold is reached, the tolerance to strong pain is decreased. So it means that often older people will put up with pain and for a longer period to a higher amount often, and some people attribute that to a history of long life with lots of experiences of pain and learning to deal with pain and having sort of more chronic pain in older life, I guess. That's some of the rationale behind that. But once they get to that threshold, then they start to suddenly not tolerate pain well, and that's where we need to come in and make sure we're managing their pain really well. The other problem too, and this is the area that we were looking at, is this combined with impairment in communication makes assessment and therefore adequate treatment of pain difficult in that group as well. So that's where we were sort of approaching things from, because that was an area of concern. So how communicating pain needs. So we've identified most of these: dementia, delirium, language, speech. If someone's had a CVA and they're dysphagic, they can't talk to you. They may have cognitively damaged, they may have a head injury, they may have a developmental disability, and also children and babies as well. So we need to use other tools or other ways of assessing these patients' pain. And I think someone before said, I wasn't sure who it was, Claire uses the Abbey Pain Scale. So Claire, is that in the acute care setting as well, the Abbey Pain Scale? Okay, cool, excellent. That's pretty much what we're going to be talking about today. How long have you been using that for in your setting? Okay, just recently. And do you know where that came from and what started that process? Are you aware of the what drove that to begin? Okay, that's cool. That's all right. It'd be interesting to find out, because when I did this study ages and ages ago, in 2008, whenever it was, there wasn't a lot around at that time using it in the acute care setting. So it'd be interesting to find out. So when we're assessing, pain aid is another scale. There's quite a few of the scales. They're very similar in some ways, and that's probably a pretty common one as well, the pain aid scale. When we're doing a normal assessment on someone's pain, we're looking at some objective assessments. So looking at the history, the type of injury, the patient's age, their pain history, their liver and renal function, what medications they're on, if they're taking any illicit medications as well. It's important to think of that, because if you have a patient who can't communicate with you, if you know that they've got a fracture, then it's highly likely that they're going to be in pain, much more than if they don't have a fracture. That sort of sounds stupid to say, but I guess we need to think about it in those terms as well. Examination, so we look for obvious injuries. If you're assessing someone and you see a very big, stage 3 pressure related injury, they're more likely to be in pain than if they don't have that. So all those things will go to add to their likely pain levels as well, especially if they can't tell you. So there's some objective assessments we can do as well. Then there's a subjective assessment, and this is where we often will be asking the patient using a rating scale. There's a whole range of different scales. There's a FLAC scale, the Wong-Baker Faces scale, visual, numeric and verbal rating scale as well. So I'll show you a few of those, and more than likely you've used some or all of those at some stage anyway. So the faces, the Wong-Baker Faces scale, you can see that one up here on the right, very similar to this one here. It's just a different version, often used for kids or someone who can point out how they're feeling and give that a bit of a scale as well. Obviously, this is the most common one. We're used to the 0 to 10. And this is a little bit of a different version here with the different colours going from nice calm blue colour to a nasty red colour with lots and lots of pain. So there's a few of those scales in existence. Has anyone used the Wong-Baker Faces scale? It's probably generally only if you've worked with kids, I suspect. Oh, Wendy has, yeah. Was that with kids, Wendy? Oh, no, okay, so you use it as well. Okay, excellent. Well, that's good. Cool. All right, this is another scale, the FLAC scale, so faces, legs, activity, cry, and consolability. This is often used with young kids or babies as well to assess their pain. So there's the different categories there. The face, what's their face looking like? Are they grimacing? The legs, are they in normal position? Are they restless? Tense? Are they kicking, or are their legs drawn up? Activity, they arched, rigid, jerking, crying, and consolability as well. So that, is a way of assessing someone's pain. Now, it's not 100% reliable. Like, if you asked, what's their pain between 0 and 10, that often will give you a much better answer, but you can't do that for this patient population. So the thing that when we were looking through the literature, we decided to try the Abbey Pain Scale, and it's developed by Professor Jane. Is it Jane Abbey? I can't remember. I did email her to get permission, but she's has worked in Australia and developed this mainly for use in the aged care setting as well. So at that stage, I wasn't aware of anywhere else that used it in the acute setting, but it sounds like there are some places now, which is really good. So this is not the final layout that we use, but this just gives you an idea of the behaviour scale. And it goes through very similar things to the FLAC scale. So vocalisation, are they whimpering, groaning, crying, or moaning? Facial expression, so do they look tense? Are they frowning, grimacing, looking frightened? Is there change of body language? Is there behavioural changes? They're refusing to eat? Are they hitting out? Is there changes in things like temperature or pulse or blood pressure outside the normal limits, or is there some flushing or pallor? Physical changes, do they have pressure ulcers, or do they have contractures or fractures, will go to making their pain worse as well. So you give that a score for each of those sections, add up the total score, decide, if you end up with a score in the moderate range, then you treat that pain, and then come back 20 minutes, half an hour later, and redo the assessment and see if it's changed. Now, one of the shortcomings, I guess, of this scale is that it doesn't differentiate between pain and agitation. So if someone is agitated and they're not so much in pain, you will get the same sorts of scores at the end, which can be problematic. I guess one of the things we talked about was if you're administering analgesia and you come back and that you do the reassessment, ideally the same person, because it's a little bit subjective. If the score hasn't changed, either it means that you're likely it's more not so much pain but more agitation, or that you haven't given the person enough analgesia to cover their pain. So it's a little bit of a judgment call, I guess, about how well that works. The other thing that I think it does, by having this chart sitting at the end of the bed, is a prompt for the nurse. And I think this is probably one of the most important parts for outside of the score, is that it actually makes the person consider this person's pain. Because in the past, if they're sort of just sitting there quietly rocking and not saying anything, then often they're not the squeaky wheel and they're not going to get the oil. So this, by that chart's actually sitting there, it means that people will think, oh, that's right, I should do an assessment, and then they take time and do that. And that's what we found on the ward. The wards that we implemented this, that's how that worked, and it was quite successful, and it's still being used today. And I'd like to see it getting used in many more places as well. I think it works really well. The benefit for managing these patients' pain is for them, but also for us as well. So, if you have a patient that's has dementia or and a delirium and they're in pain, they're more likely to be resistive. They're not going to help you when you're turning. They're going to hit out. They're going to push against you. They're not going to stand well, but because they're in pain, and that's quite reasonable. If you're in pain, you don't want to be getting up and wandering around. So if we can manage their pain better, they're less likely to be resistive to those things. So that's better for them in the long run, but also better for us. So we're less likely to get injured. We're not going to hurt our backs or in shoulders trying to mobilise someone who's in a lot of pain and keeps collapsing. So there's a benefit for both of us as well. So that's why I think it's really important to consider these patients' pain. So I guess the recommendations that came out was encourage all staff to think about the older person, and especially those who can't express their pain needs clearly. Think about, is the confusion actually worse because they're in pain? So it might be feeding off each other a little bit as well. Are they resistive to intervention? So if you're getting someone who's continuously hitting or resisting any sorts of interventions, then maybe that's an element of pain to that as well. You don't want to narcose them with too much analgesia, but you want to get a nice balance. Are they not mobilising because they're in pain? If they're not doing that, then they're not getting better. They're staying in hospital longer, so that's bad for them as well. Making sure that we give them adequate analgesia before the interventions. So many times I've seen people give someone some subcut morphine, and then 2 seconds later they're trying to get them out of bed. You've got to let that work and give it the adequate time as well. Don't always withhold analgesia just because the patient's confused. I guess the thought process sometimes is that'll make the confusion worse, and I guess that's reasonable consideration, but at the same time that might be working the other way around. So just consider that for your patients as well. And so if we can spend a little bit more time assessing and treating these patients, and it might actually mean less work for us in the long run as well. So, and that can decrease the risk to them and also to us as well. And then the last recommendation was using a behavioural pain scale like the Abbey Pain Score or the Pain Aid Scale. Lots of different ones around you can use, and they're all very similar in the way they are designed, but I find them very useful as well. How do you, Claire, how do you find, have you sort of been working with the Abbey Pain Scale long enough to make a comment on how well it works in your setting? Sorry, it's a bit hard when you got to type. It's not, okay, it's not receivable. Yeah, it's probably a little bit, okay, in ED, that's interesting. I hadn't considered it there, yeah. I think it's about getting the nurses to understand the benefits of it, and it does actually take a little bit of time, and that's the thing that's a little bit, I guess, leads to a bit of hesitation that if you spend a little bit more time assessing them, it actually might work out better in the long run. But it's hard to get people to appreciate that. But it does, yeah. Anyway, I'm a strong believer in it as well. So anyway, these were the group of people that worked together on the project, and I know I used to got it on S3 as well. That's excellent. That's good. Yeah, so these are the people that worked on the project with me. So that's some acknowledgements to them. So that's pretty much the presentation. I kept it to almost half an hour exactly. Excellent. Is there any questions or any comments you want to make about that topic? That's a good question. I guess trying to help them to understand how serious pain for this patient group can be, and how easily, I guess, how easy it is to underestimate it. I guess that's the first step, and then also understanding that if we take a few simple steps now, it can actually save us time and make the patient experience a lot better in the long run. So you're going to have patients who are less likely to be hitting you and being resistive to things, but that's hard to tell people that, I guess. But that's all. Yeah, being it's having some sort of educational package and getting them to talk about it and spending time, and it's these days trying to get time and talk about things is can be really difficult as well. Claire saying, so our problem is that numeric rating scale is included in an OBS chart. Yeah, so it's separate, definitely. And that's one of the big problems I had trying to get it in to the hospital as a accepted thing throughout the hospital as well, which was a struggle and not one that I won, unfortunately. But yeah, having it separately is difficult. We often have ortho juries come in. Yeah, I know, and sometimes that might be the case, but I think I don't think you should assume that the analgesia is contributing to the delirium, and that's it's a bit of a hard call because it's hard to say, but if you do that and nothing changes, then it's likely that delirium is something else, or I would probably suggest, maybe you lower the dose and you increase the frequency or something like that. That's probably a better option rather than just ceasing it altogether. That probably worries me a fair bit. And Laurie, very reluctant. I'm getting a lot more fractured NOFs coming in. Yeah, and yeah, definitely can be very difficult as well. Yeah, and sometimes the relatives think the analgesia definitely. Yeah. I mean, there's some interesting feelings out there in the world about, taking narcotics, you get addicted straight away, and there's lots of problems with that. So, yeah, that's a bit of education needed for the family sometimes and the patient. And look at things definitely like the nerve blocks as well. It's an area that's sort of starting to become a bit more popular in orthopedics, and even some of the nurse-initiated actions for that as well. Yeah, so and Laurie's seeing a lot more as well. Yeah. And that's, I mean, that's a good thing too, because you're not getting those side effects, but hopefully you're managing your pain much better as well. FIBS, what's FIBS stand for, Claire? Sorry, excuse my ignorance. Oh, okay, of course, that makes sense. And who's doing those, Claire? And where? Is that in ED or in the wards or in theatre? Yep. Oh, cool. Oh, that's good. Yeah, that seems to be happening a lot more as well, getting nurses to do that, or nurse practitioners or someone. That I think that makes it better for the patients. They don't have to wait around for a doctor if they're busy or caught up in theatre, I guess, and the anaesthetists as well. Cool. Oh well, that's good. I'm glad that sort of stuff's starting to change. That's excellent. So you're done in ED or OT, not on the ward yet. Yeah. I know that's starting to happen in some places on the ward, but obviously, you want to try and get in as early as possible. And ED makes sense. You've got all the other staff there for support rather than waiting till they get to the ward and then you're trying to transfer them on from the breach onto the bed and causing more pain as well. Hopefully they're getting people straight onto beds anyway. That's always good. So Claire, yes, we can only have the second one. Oh, okay, right. So the first one has to be in ED or OT, I guess. And Wendy, we trial femoral nerve catheters. Has that worked okay, Wendy, the femoral nerve catheters? And Laura's seeing more arrive with blocks in situ from ED. Yeah, that's good. I think the only issue is depending on where the catheter is going and what sort of medication you're using. You don't want. I mean, it doesn't matter so much pre-op, I guess. You don't want any decrease in strength, but post-op, that's a different story, I guess. So I still have some reluctance from anaesthetics. Yeah, so you got to convince everyone else. That's the tricky bit, I guess. Cool. Well, it sounds like there's a lot of different stuff going on out there. It's really interesting. All right, guys. Well, if there's no other questions, thanks for coming along tonight. I hope you found it useful. Spread the word out there about this patient population, and hopefully we can get some stuff changing. Just keep in mind you can get some CPD points for these sorts of sessions as well. You technically, whenever you do something like this, if you get audited by the by APRA, you need to have some reflection on the actual topic as well, not just have the date and the topic written down. So anyway, see how you go. I heard that the other day. Cool. All right. Well, thanks guys for coming along, and keep an eye out. We've got some more coming up. I think Wendy's got one booked in for October at some stage, but we'll put stuff on Facebook. If you're, I think you guys are probably all on the ANZONA Facebook group. If you're not, have a look and join. Otherwise, we'll send out emails as well. So Natalie's starting to get, yeah, happy days. I've heard bad things about getting audited. And Wendy, no worries about the wrong time. That's no dramas. Like I said, I didn't even notice it until today as well. All right, thanks guys, and we'll see you next time.